while people can join, we are recording. Just wanted to repeat good morning and good afternoon to folks who are joining us. I am so grateful for you making the time in your busy schedules to join us today. My name is Sarah Glick. I use she, her pronouns, and I am at the University of Washington. I also work with our local public health department, Public Health Seattle King County. And I am going to be one of the co-presenters today with my colleague, Kelly Knudsen, who will introduce herself in a little bit. And today we're going to be giving really the final presentation of a very long project that we have been working on, focused on data indicators for syringe services programs. And today we'll be talking about the implementation of these indicators, and we're really thrilled to announce that our guidance is officially up on the website. I'll mention where you can find that in just a minute. And without further ado, I am going to jump in to today's agenda. So next slide, please. I'm going to start by giving a very short introduction and project description. For those of you who have participated in some previous webinars or even some of our in-person work, you will know that this has been a long project. There's a lot we could talk about, but today I'll just be giving a really short overview of that. The second part will be hosted by Kelly, and she'll be giving a tour of the implementation guide for folks who work at syringe services programs. In previous presentations, we've gone in depth with each of the indicators. Today, our goal is just to show you what kind of information that you can expect to see in the guide for each indicator. And Kelly will dive into just 3 indicators to look at what kind of information each one has and how you and your programs might go about implementing them. And then the third part will be a discussion that's really aimed at funders or other entities like local or state health departments that collect data from SSPs. So we know this won't apply to all of you on the call, but it will apply to some of you, and we hope that it is still important information for all of you. Here, I'll talk about some of the lessons learned from our project and considerations that funders can take when thinking about data. This project was conducted by the Supporting Harm Reduction Programs, or SHARP team. We are at the University of Washington. We're housed in our School of Medicine's Division of Allergy and Infectious Diseases. The University of Washington, for those of you who don't know, is a public research university in Seattle, Washington. Our team is a collaboration of researchers and staff at the University of Washington who have experience working with and at harm reduction organizations. We have expertise in harm reduction, research methods, evaluation, working with people who use drugs, data collection, analysis, and monitoring and evaluation. And most of our work is specific to syringe services programs, or SSPs. Some of us, I think 2 of us, are in Seattle, including myself, but our team is a fully remote national team. So we do have team members in Knoxville, Tennessee, Durham, and Chapel Hill, North Carolina, as well as Brooklyn, New York. Our team has a lot of resources on our website that we've created around harm reduction data and data collection at SSPs. The guide that today's presentation is based on was just posted to our website, and we do have a ton of other resources as well. Our website's there, our email's there. I also want to note that our team offers technical assistance to SSPs and harm reduction organizations, as well as health departments on harm reduction topics. Data is our specialty, but we are able to offer technical assistance on other topics or help you find a different source of technical assistance that might be out there. So you can reach out to us if you have questions about technical assistance, or you can learn more just from us in general through our email, which is sharpta@uw.edu. And then the final plug I will put in is we do have a listserv that you can sign up for. You can use this QR code or this URL. I promise we don't send out a ton of emails. We only send out emails when we either have new resources or we are announcing things like trainings. We do host in-person trainings on occasion. And so you can sign up here through the QR code or again through this list. Or if you forget all of that, you can just reach out to us by email. So our technical assistance team, as I mentioned, focuses on supporting harm reduction programs with monitoring and evaluation, and that includes data systems, methods, and data collection. And as a team, we have devised a set of team values and guiding principles that we use when providing any sort of technical assistance. First and foremost, we always know that providing services to our participants comes first, and that collection of data comes after that. So it is a second priority. We always advocate for implementing data systems that maximize client confidentiality and ideally client anonymity whenever possible. We're always working to minimize the burden of data collection, both on the programs who are collecting it and especially on the participants who are providing it. We advocate for only collecting data that can be used to benefit people who use drugs and the programs that serve them. And then finally, we fully recognize that, if you've seen one SSP, you've seen one SSP. There is no one size fits all. We do our best through some of our guidance to try to reach as many types of harm reduction programs as possible, but we do realize that every program is different and needs to make changes or tailor work to their particular program. So as I mentioned, I do want to share just a little bit of history about this particular project and its funding. This project started last year when our team was funded by the CDC as part of the National Harm Reduction Technical Assistance Center. This work really came out of our general technical assistance work, where we were often asked by programs, what data should I collect? And through those requests, we decided that we wanted to aim to develop community-informed indicators that can be recommended to SSPs and other harm reduction programs. As some of you may know, as of December of 2023, our funder for this particular part of the project, NACCHO, and ourselves at the University of Washington, we are no longer part of the National Harm Reduction Technical Assistance Center. And so this work, which started there, has continued with different funding. Our funding comes directly from NACCHO, which itself comes from a different CDC funding source. On our website, we have a lot more information about the background to this project and all of the methodologies that we used up until this point. So I'm not going to go over those today. If you're interested, please check that out. And our final step of this process was publishing our implementation guide and reporting it back to community. And so that is what we are doing today. So this is the final step in our project. And so with that, I'm going to turn it over to my colleague, Kelly, who's going to walk us through the indicators, and then I'll come back later in the presentation.
Thanks, Sarah. Hey, everybody. So I'm going to talk a little bit about what's in the implementation guide and what to expect. And so to start off, I just want to talk about what we say when we say an SSP indicator. The indicators are basic data points that could be collected at a wide variety of SSPs, and they have a focus on a couple of topics. One, basic SSP services, so the provision of safe use supplies and naloxone, descriptions of the programs, descriptions of participant populations, and then some descriptions of participant experience. We don't mean the indicators to be all of the data a program collects. We anticipate that programs, most, if not all programs, will collect more data, as Sarah mentioned. There's such a huge diversity in SSPs and their services, their service models, their setting, and their goals, and all of those and more will have an impact on what data a program collects and how it's collected. So that will impact what indicators, what data they collect and what indicators they use. We intend the indicators to be used for internal program evaluation and then external program communication, namely like advocacy and grant writing. When we went through this process of creating the indicators, we had some goals, and they were to make them low barrier for participants and low barrier for staff, while also aiming for a high quality of data, so accurate, complete, and usable. And we really leaned hard towards being protective of participant and privacy and confidentiality and anonymity as if possible. So as we mentioned, there's no right way to collect them. And so in the guide, we have recommendations about what methods we might recommend, and then considerations if you're using other methods. And as I've mentioned, programs will really need to think about what is and isn't important to them when they're making, and what their goals are when they're making decisions about what they want to collect and how they collect it. All of the recommended indicators we have could be collected without using a unique ID, so they can be collected anonymously. And then the guide has information about the project, some background information. It has some basic monitoring evaluation information for SSPs. And then it really goes in depth on each of the 18 indicators. It has a glossary because we're nerds, and also a checklist around like if you were going to use them and thinking about how you might implement them at your program. It also has, as Sarah will talk about, our consideration for funders. And then lastly, it has a guide to other online resources that we have that complement the indicators guide. So just a quick mention of what's like not in scope in this. The indicators don't include case management or infectious disease testing, because both require identifiable information. So like first and last name, contact information, birth date. And ideally, SSP services are anonymous, and most case management infectious disease testing are confidential and not anonymous. We recommend that case management or infectious disease testing data is documented separately from SSP services so that SSP services can remain anonymous. And as I mentioned, all of the indicators we recommend can be collected anonymously. Second, we don't cover HIPAA, and nothing in the guidance will go into whether or not your organization needs to be HIPAA compliant. It's just not within the scope of this at the moment. And then third, it doesn't focus on participant outcomes. So as I mentioned, it focuses on program and like internal program use and evaluation. So there's two main reasons we don't talk about participant outcomes in that. And the first is they're just incredibly hard to track, especially within the standards we set for ourselves in the project. So all of our indicators had to meet 3 standards: that they could be collected across a wide swath of SSPs, that they could be collected ethically for participants and staff, and that they would lead to high quality data. And most participant outcome data would struggle to meet any of those standards. And the second reason is that tracking participant outcome data often requires unique identifiers, and we were really trying to maintain a data set that could be anonymous. And then lastly, this doesn't include community level indicators, partially because, as I mentioned, we're focused on internal program evaluation, and partially because community level indicators require external data sources. And this is based on data a program can collect by itself. So there's 18 indicators split into 7 domains, and I'll review I'm going to review all 18 of them briefly, and then I'll go into a couple of them more in depth. So you can kind of see like what kind of information to expect and the level of detail in the guidance. The first domain is service and supply provision. And so these focus on the services that a program provides and the supplies that they distribute. The 3 indicators in here are the count of syringes distributed, the types of services a program provides, and the types of supplies they distribute. And this format of the table you'll see in this presentation as well as in the guide. So the format column refers to how we'd recommend reporting indicator out, and data source recommend where the data would have come from to calculate or write up an indicator. So as you can see, for these 3, none of them require asking questions of participants. Like for count of syringes distributed, you need some way to record the syringes out, but you wouldn't itself be asking that of participants. Our second indicator our second domain is service coverage. So at a population level, service coverage is thinking about like the geographic reach of a program, and on more of an individual level, it's looking at the level of engagement, the level of services, and the comprehensiveness of service provided to participants. So the three domain indicators here are the hours per week a program operates, a program service model, and total participant visits. The third domain is service quality, which is concerned with the effectiveness of services at improving the well-being and meeting the self-identified expectations of participants, staff, and volunteers. So the indicators in this domain are program activities and program needs and barriers to service provision. The fourth domain is engagement with people who use drugs, which looks at the ways a program empowers people who use drugs, includes people who use drugs in decision-making, and collects feedback from people who use drugs to incorporate into programming. The indicators are how people who use drugs are engaged to give feedback about a program and how participants have decision-making power in a program. The fifth domain is overdose prevention, which focuses on program services and activities directed towards preventing fatal overdose. The indicators are count of naloxone doses distributed, participant overdose experience, and reported overdose reversals. And these are the first three indicators that would require, well, two of these are actually the first ones that require collecting data directly from participants. The sixth domain is demographics, which is focused on describing the characteristics of a program's participant population, and the indicators are participant age range, participant gender, and participant race ethnicity. And our last domain is structural violence, or the ways that local, regional, and national systems and institutions, including economic, political, cultural, and legal institutions, affect the lives and health of participants. And the indicators here are participant housing status and interactions with law enforcement. So today I'm going to go in depth on these four indicators: count of syringes distributed, how people who use drugs are engaged to give feedback about programs, participant overdose experience, and participant age range. Just so you can kind of, folks can see what to expect in them, and what you kind of the thinking about how you might adapt these to your own situation. So first, we're going to talk about count of syringes distributed. So the main sections in every indicator are definition, use, collection, and considerations. So here, definition is pretty straightforward. It's what we consider the definition of the indicator. For this one, the count of syringes distributed is an estimate of the number of syringes a program distributes over time. And this would be reported as a number. So programs will want to define a time that works for them. Annual is likely the most common, but internally, some programs might look at shorter periods of time, like monthly or quarterly, to look for patterns or trends. And I'm sure you all are aware, this is a very common data point that many, if not most, or all SSPs are already collecting. So the use section includes information on why the indicator was selected, potential uses for program improvement, and potential uses for advocacy. For this one, count of syringes distributed was selected because it met our standards of ethical, flexible, and quality. It can be collected in a low barrier way. There's no need to ask participants. There's various ways to do it that involve minimal staff time. It doesn't require a unique ID, and without a unique ID, it doesn't pose a risk to participant privacy, confidentiality, or autonomy. Many, if not all, programs will find this useful when they're applying to funding. And when tracked over time, it may reveal trends or patterns and can give programs a sense of size and demand. And it can also be used to inform inventory and decision-making. The next section is collection, which includes thoughts about methods and considerations for how the indicator should be collected. Count of syringes is pretty straightforward. Mostly it's going to be collected either with an inventory or an encounter system. I'm not going to go in depth into what those are. Most people are using one or a combination of those. But when deciding how to track or collect it, programs want to think about their service model, their staffing, and their goals. For instance, if a program is moderately high volume and wants to offer quick anonymous services, an encounter system where staff are marking how many syringes are out with a unique ID would meet those goals. The considerations section includes information on the limitations of an indicator, often what it can't tell you, how it could be adapted, and ways that you might want to think about analyzing the data. for count of syringes distributed, the main limitation are that the count of syringes distributed doesn't alone and can't tell you if you're meeting the syringe needs of your participants, with like a new syringe for each injection or an injection attempt. And nor can it tell you if syringes are being distributed to the people most in need or equitably across participants' populations. You would need additional information to assess those points. We don't believe programs need to track syringe type, but they may want to. And we don't believe that information needs to be reported outside of the organization. Lastly, each indicator includes an example to think about like what this might look like in reporting. So here we have an example of what it might look like to be reporting in total syringes out by quarter. The second indicator we're going to talk about today is how people who use drugs are engaged to give feedback, which we define as a record of an SSP's approaches to collecting and recording input from people who use drugs about the overall program, including services, supplies, and structure. And this would be recorded as a list or a narrative. So this was selected because it met our standards of ethical, flexible, and quality. I'll note that the indicator itself is about the methods of engagement, not the actual feedback. We do believe that internally the feedback needs to be documented, but that it doesn't necessarily need to be reported externally. And documenting the methods can be a low barrier way that doesn't require asking questions of participants. And in terms of internal use, feedback from people who use drugs is the most effective program improvement. And if you're being intentional and direct about what your program does to get that feedback is critical in assessing where you're at and your capacity to include people who use drugs at every level of your organization. In terms of collection, so, since this is just methods, we encourage people to have a list that they update on some kind of regular basis, so like annually or quarterly, depending on how often the methods might change. And like when possible, documenting like what the actual feedback is and what changes come of that. In terms of consideration, the major obvious one is just that if you're documenting the methods, it doesn't actually or the feedback, it doesn't actually necessarily indicate the level of engagement. And those, of course, are critical to consider and so you can improve over time. And that this is going to be most meaningfully documented if you document context around what feedback was provided, what was done, and what was successful. Our third indicator is participant overdose experience. So this is a record of an SSP participant's experiences with themselves non-fatally overdosing. So this is not about them witnessing other people overdosing. I'll note this is a really sensitive data point, and folks will want to really consider how it's collected and what that experience could be like for participant and staff. I'll also note that the way we've defined this is inclusive of opioid and stimulant overdose. And if folks want to focus on one, that they'll need to more narrowly define that for themselves. In terms of use, this does need to be directly asked of participants, and there is a certain burden associated with that, but this can have a lot of use. It can really help programs understand participants' experience and the burden of overdose and think through how they may be able to respond to that through education, services, and advocacy. And also in a lot of areas of the country where fatal overdose surveillance is inadequate or inaccurate, it can be important to have creating a larger picture of what's going on. I will note sometimes we find programs ask about overdose as a way to ask if people need to like re-up their naloxone or if they're interested in services like drug checking. And we recommend that folks be really direct and like if you're interested in if people need naloxone, just asking directly, do you need naloxone, and not asking them about overdose experiences because it can be traumatizing for folks. In terms of collection, like I mentioned, you have to collect it directly from participants, and participation in data collection should never be required in order to receive services. When asking things from participants, they need to be asked openly, so not assumed, and directly from participants, but in a private place, so they're not overheard. And from our experience, most folks are currently collecting data like this via an encounter forum. We recommend a point-in-time survey for two main reasons. First, when you're asking in an encounter form, it can be intense for participants to get asked about a sensitive and potentially traumatizing topic at every visit. And then second, from a data quality standpoint, it's pretty complicated. You kind of both have to consider that you'll likely have duplicate data from folks reporting the same event more than once. And it may also be an undercount if folks are not reporting something that they don't want to talk about. So with the point in time survey, you'd ask a lot less frequently, for instance, annually. And then based on that data, you could get an estimate of what percentage of your population has experienced an overdose. And for instance, in our recommendation, the last 6 months. If you wanted to get an estimate of the number of overdoses, you'd need to ask additional questions. And I'll note that the time frame is flexible here. It doesn't have to be the last 6 months. It could be the last month or the last 3 months, but you likely don't want to go longer as it can impact folks' ability to recall. And lastly, for considerations, some of as you'll see for this one, there's a lot to consider. As I mentioned, it's a sensitive topic. So really thinking about like what is your goal with asking about the data, and how can you meet those goals in a low impact way for your participants? If you're collecting it on a point in time survey that has demographic data, you could be stratifying your data to look at how overdose experiences are different across race, ethnicity, age, gender identity, like variety of different topics. Sorry. Lost my page there. As I mentioned, we included the question we've created includes both stimulant and opiate overdose. You could ask separately about those, but due to the contaminated drug supply, participants themselves may not know what they're taking. So even if you do try to parse those out, you still might have some data quality issues there. And then kind of our last 2 points is for any quantitative data, you really want to be reporting it out in aggregate. So like in a table, not line by line, and not attached to a unique ID in order for it to be anonymous. If you're collecting any qualitative data on this, that should also be reported anonymously and de-identified so that it can't be recognized. And the last indicator I'm going to review today is participant age range, which is a count of the number of SSP participants categorized by age range. This can be used to estimate the age range of a population, and in order to be anonymous, you'd want to report this in aggregate, like in a table. In terms of use, I think broadly, demographic information is helpful for programs to understand who they are and are not serving. It can be helpful in terms of like describing your program and figuring out how you might want to address equity or make changes to address certain participant populations. In terms of collection, one of the reasons we want to talk about age range on this is might seem unusual to recommend age range over age, but age range offers more privacy and security to participants than age. Demographic information, when collected together, even without identifying information like name or contact information or unique ID, can be identifying. So by collecting an age range instead of an age, it becomes slightly more difficult to identify people. It should be collected openly and directly from participants. We shouldn't assume it. And a point in time survey is what we recommend, as it allows for high quality data with low missing data, a low data burden the rest of the year. And the real limitations to collecting it via an enrollment or encounter form it becomes really difficult to analyze. There's a lot of missing data, and it can be difficult to report on since maybe it's like age at enrollment and that's not where they are anymore. We don't recommend collecting birth date because that is highly identifiable. And so for considerations, I've hit on a couple of these, but the main reason you would collect age over age range is really that we see that funders have different age ranges they want to report. So we understand that's a big limitation for SSPs. But the reason to try to go for age range is that it's just potentially less identifiable. We encourage folks never to ask for birth date since it's a high risk to participant privacy and confidentiality. And then folks want to be careful about data with minors. So in most places, there might be limitations about providing services to minors, and minors would likely be careful to reveal their age if it might mean they don't get provided services. So if you're asking about age range, having the youngest age range be inclusive of 18 allows some protection for both the program and the participants in that. And then lastly, as I mentioned, it should be reported out anonymously in aggregate. Great, I'm gonna pass it back to Sarah to discuss considerations for funders.
Great, thanks, Kelly. So for this last part, I'm going to go into about 8 considerations for funders or other entities that collect data from SSPs. And these considerations all came from interviews that we've had with SSP staff. It comes from some really rich discussion that we had during our in-person convening that informed these indicators. And then also from what we heard during the series of Sharp Salons that we hosted, which was a series of 3 webinars where we talked with a lot of folks who work in harm reduction and listened to some of their ideas and concerns about implementation. So, next slide, please. So our first consideration is transparency for applicants. And so what we're asking from funders is to please include information on the data that you will require as part of funded projects, how you'll require it, and how often it will be required when you are putting out your calls for applications and proposals. This allows applicants to better assess if the data requirements for the grant will work with the data that they are already collecting. It also helps them think about how much time they may need for monitoring and evaluation in their budget. What we hear is that programs are often blindsided when funding comes with large data requirements and they don't have an adequate staff or budget to collect this data because it's so different from what they're currently collecting, and that change requires significant time, money, and effort. We also have heard that requirements that are considered optional can still be burdensome, and often they are read as being required, since many programs are simply hoping to please their funders in order to maintain their funding levels, since, of course, harm reduction programs are often so under-resourced and scarce. The second consideration is to provide data collection resources. So we would encourage you to consider providing technical assistance or other support to programs that might need either assistance or help implementing new reporting requirements. So what would that look like? It could look like offering specific targeted guidance to grantees. It could allow for funding for monitoring and evaluation. It could allow for needs like software or funding for training to help scale up that data collection. And you might even consider having experts on your team to help support other programs in their growth. The third consideration is related to flexibility. And as we've both noted in this presentation, we know that there is no one size fits all when it comes to really any of this, and it certainly applies to there being no one size fits all for data points, methods, and then systems across SSPs. So it's important to, ask yourself as a funder, how can you adjust your requirements to meet your grantees' current data practices and their current preferences? And is it possible to accept data in the form that grantees are already collecting, even if that means reducing some of the comparability that you would have across grantees? The fourth consideration, and one that our team works really hard on, is to minimize data requirements. Many of the funding sources for SSPs are pretty small, and so many programs have many grants. And if each of these grants requires multiple, slightly different data points, it really adds up to a significant burden and barrier to services for participants and staff. We know that the local context across programs across the country can vary greatly, so what's acceptable to ask in one place might not work in another. So it's really important to allow grantees to pilot data points with their own participants and then give and integrate feedback about what worked in their context. We also ask that you be clear to yourself about how you are going to use the data, and then be clear to grantees about what that use is. This really helps with buy-in and data quality, as SSPs will be able to provide important local context for interpreting the findings. And then finally, minimizing data requirements is one way to protect participant privacy and their confidentiality. And just in general, the less data that SSPs need from participants, the better off they will be. The fifth consideration is to consider coordinating and synchronizing reporting requirements with other funders or government entities in order to reduce burden and hopefully foster higher quality data. So I think it's important to ask, is it possible for there to be standardized application questions in order to reduce the time that programs spend applying for grants? And I think this is especially true for all of those smaller amounts of money that programs are often applying for. The sixth consideration is to remember that SSP or harm reduction data is not epidemiological surveillance data. And I certainly understand that there is an underinvestment in epidemiological data around drug use and overdose, really on all levels, federal, state, local. And it can be difficult to make some really important assessments and decisions without that data. However, unless programs are specifically funded to be collecting surveillance data, which sometimes they are, SSP should not be assumed to be the source of that data. And what SSPs are collecting and reporting really should first and foremost meet their internal evaluation goals in order to improve their service delivery. Some SSPs that do have significant resources might be able to conduct more higher threshold data collection activities, but it should be time limited and relatively infrequent, and their participants should be adequately compensated, whether that be through fair wages, cash when possible, not providing gift cards, and in order to compensate them for their time, participation, and expertise. The seventh consideration is that all data should be reported to grantors or funders or other reporting entities in totals or proportions, and that's what we call aggregate data. That is opposed to what we call line by line data, that is data that's parsed out by individual participants. And so we ask that data be collected in aggregate in order to protect participant privacy and allow SSPs to implement data security safeguards. And then finally, we ask funders to really consider the trade-off between data quantity and data quality. And as I already mentioned, the amount of data that can be required by funders can balloon and be so substantial that the quality of the data can suffer. And that can occur because programs are not funded adequately to collect and analyze data, that the large quantity of required data collection can negatively impact the services that they provide to participants if they're having to spend so much time collecting data as opposed to providing services. And then finally, over time, both participants and staff develop, data collection fatigue, where folks just get tired of asking and answering the same questions over and over. And so we also want to note that a lot of the data collection that can be required can be quite sensitive to participants. And, the questions asked about overdose experience, for example, can be very traumatizing, stigmatizing, or even offensive to participants. And so asking those questions does require a lot of care, and also does need to be taken into context that when programs are asked to ask all of these questions, they're really put in the position of either asking participants for data that might make them uncomfortable or meeting their grant requirements. So it's a really difficult trade-off for programs to make. I think that is it then. All of the considerations that I just went through, all of the indicators that Kelly reviewed, and then all of the history of this project can be found on our website. Like I said, the implementation guide was just posted, I believe, this morning. And so you can find it there on our website. That's also our contact information. And then before we allow time for some questions, the next slide again just gives you information for joining our listserv. There we go. There's the QR code for joining our listserv as well as our address for joining that. And so at this time, we open this up for any questions or comments that you all have. We really hope that you find this guidance to be useful to you and your program, that you can think of ways to adapt it for your own needs, and that you also don't hesitate to reach out to us if you have questions about the guide in general or about your program specifically. Like I said, we are available to provide some technical assistance. We love hearing from programs, love hearing what works and what we don't love hearing what doesn't work, but we're love to help you think through what hasn't worked for you and try to come up with some more effective strategies for your own program. So thank you for paying attention, for being here today, and we'll stick around for any questions. Appreciate the kind words in the chat. Maybe we have finally been so clear with this that there are no additional questions. Well, we'll stick around if there are questions, but feel free to go on with your day if you would, that is good for you. Thanks, everyone. This is really nice.
I don't know if y'all saw the one question. It's if we've used any arts-based methods to engage participants.
Oh, great. I see that now. Sorry, I missed that before. I am not familiar with, I have not done so myself. I'm curious if others on the SHARP team have used that or know of any of that. Any examples of that?
I have not, I know I think Sophie's actually on the call. Some folks have used photo voice as a method to engage participants. But I'm not aware of many other arts-based methods. But I think that is like a wonderful method to consider.
Yeah, photo voice is a good one. I would suggest looking at an article done by Dr. Jack Burrell and Dr. Anna Pruitt on using photo voice with Housing First participants. That was like a really good kind of seminal work on it, and that can be translated pretty well, I think, to using, other vulnerable populations. So I think that would be a good place to start if you were considering it.
Oh, that's great. Thanks so much. Would you mind putting the citation in the chat?
Yeah, hold on. Let me find it and pull it up. I can put it in there.
Awesome. Thank you so much.
You might also look at Project Mayday out of West Virginia. They just did a recent sort of storytelling book, and you can find it on their Instagram. But I'll go ahead and put the program name in the chat, and they're in West Virginia.
Wow,
Thanks,
that
Sophie.
sounds amazing. Thanks. Yeah.
Yeah, thanks, Sophie, for doing that.
I also put, there's, this made me think of it. There's a group called the Center for Story-Based Strategy that does a lot of training around story-based building, which is not necessarily an arts method, but I think is kind of related to what we're touching on here.
Mhm.
If folks don't have any other questions, we're happy to end early to give folks back time in their day. But please feel free to unmute or put any questions in the chat if you do have questions.
Thanks, Sophie. Really appreciate that. Thanks, Lauren. I know everyone's so busy.
And then page 30 to 44 of the Housing First Year 2 report that I just put in there has the actual like photos and such that. So like the article that I put in there is the, like academia article they published on it, but it doesn't have like the photos and everything because it's academia stripped down, no offense. And then the Housing First program evaluation that I just put in there. If you go to page 30 to 44 of the report, they have the actual photos and things like that. So you can see the because it's a program evaluation. So then you can actually see like the work that the participants did and get more of an actual like program feel for what it was like. So I think that might actually be more useful to people on this call. So if you look at the HF Year 2 report that I just plugged in, that's probably even more helpful.
Thank you, Sophie.
Yeah, that's great, Sophie.
Well, it sounds like we're good. So I'm just going to call it. Thank you, everybody, for your time today. And please reach out to us if you have any questions.
Thank you all.